Dear doctors, today, we will discuss an interesting case to deepen our understanding of clinical decision-making. Mr. Rodriguez, a 70-year-old male with a history of type 2 diabetes and hypertension, presented to the emergency department with a 4-day history of progressive breathlessness, high-grade fever, cough producing greenish sputum, and chest pain. On examination, he appeared distressed. His respiratory rate was 30 breaths per minute. His heart rate was 110 beats per minute, and his temperature was 38.7 degrees Celsius, 101.6 degrees Fahrenheit. Auscultation revealed decreased breath sounds and crackles at the right lower lung field. The remaining examination was unremarkable. A chest X-ray showed consolidation in the right lower lobe. Laboratory tests showed leukocytosis and elevated CRP levels. Blood cultures were taken and the patient was started on empiric broad-spectrum antibiotics, pending culture results. Supplemental oxygen was administered, and he was admitted to the hospital for further management. This case exemplifies the complex nature of diagnosing and managing pneumonia, especially in elderly patients with comorbid conditions. Mr. Rodriguez's presentation of fever, cough with purulent sputum, and respiratory distress, along with the physical exam findings of decreased breath sounds and crackles, are classic for pneumonia. The chest X-ray confirmed the diagnosis by showing consolidation, typical of bacterial pneumonia. In this case, the patient's comorbidities, type 2 diabetes and hypertension, played a significant role. Both these conditions can lead to a weakened immune system, making him more susceptible to infections. Furthermore, these chronic conditions can complicate the management of pneumonia. For instance, poor glycemic control can prolong the disease course and impair the patient's response to the infection. The decision to hospitalize Mr. Rodriguez was based on multiple factors including his advanced age, severe symptoms, comorbidities, and the potential for rapid deterioration. Hospitalization allowed for close monitoring, timely intervention, and appropriate supportive care. Broad-spectrum antibiotics were started empirically to cover the most likely pathogens causing pneumonia in this patient's demographic and clinical context, such as Streptococcus pneumoniae, Haemophilus influenzae, and atypical bacteria. The selection of antibiotics was also guided by the severity of the disease, the patient's allergy history, and local antimicrobial resistance patterns. Considering a hypothetical scenario where the pneumonia was viral, the management would be different as viral pneumonia often does not respond to antibiotics. Instead, the mainstay of treatment is supportive care, including rest, hydration, and control of fever and pain. Specific antiviral therapy would depend on the identified viral pathogen. Prevention of future episodes of pneumonia in Mr. Rodriguez involves a multifaceted approach. Good glycemic control and optimal management of his hypertension are essential. Lifestyle modifications, including a balanced diet, adequate hydration, and regular exercise, should be recommended. If he's a smoker, smoking cessation should be emphasized. Lastly, vaccinations have a crucial role in preventing recurrent respiratory infections, especially in older adults. In Mr. Rodriguez's case, both the pneumococcal and annual influenza vaccinations are recommended, given his age and chronic health conditions. This case underlines the importance of comprehensive and patient-centered care in the management of complex conditions such as pneumonia in a geriatric patient with comorbidities. Each case should be approached with a thorough understanding of the individual's specific risk factors, clinical presentation, and treatment options to optimize care and improve patient outcomes.